But yeah, without further ado, as I said, it's a great pleasure to have Tamara back. And Tamara, the floor is yours. So over to you.
Thanks. I'll just share my slides. Okay, can everybody see those?
Yes, I can see it.
Brilliant, excellent. Okay, so I'm Tamara Backhouse, and as Michael said, I'm a research fellow funded by the Alzheimer's Society. And today I'm going to tell you about the findings from my fellowship study. So the study looked at refusals of personal care assistance in advanced dementia in both care home and family settings. So today we're going to cover what are refusals of personal care in dementia, and then a little bit about what the Procare study is or was, and then look at those findings from the study. And just to say that the views expressed are mine and my colleagues and the research teams, and not necessarily those of the Alzheimer's Society. So, refusing assistance with personal care in dementia. So assistance with personal care is any physical assistance given to the person in connection with activities of daily living. So this would be eating or going to the toilet, washing or bathing, things like that. And people with dementia sometimes refuse assistance with these for multiple reasons. And refusals are most common in the advanced stages of dementia. And they also occur in family, hospital and care home settings. So ways of refusing care. So sometimes people can verbally refuse, stiffen their body, push things away like the towel or a toothbrush, be verbally cross or aggressive or physically aggressive. They can grip onto things, hug things, lean or look away, clamp their jaw maybe, ignore the caregiver, or just not physically cooperate. And there might be multiple reasons, valid reasons for a person with dementia refusing care. So refusals of care often start in the context of a person with dementia and all their health status and how they're feeling that day, the caregiver and their approach, and environmental factors. So is the room cold? Is it warm? Is there equipment that's needed on hand? And then the caregiver will attempt to help the person with some activity of daily living. And this might be acceptable to the person and they're quite happy to go along and care is delivered. Or it could be unacceptable to the person for whatever reason. They might be in pain, or the caregiver might be approaching them too quickly and they may refuse care. So the caregiver may then try to encourage the person or put in place some strategy and care is delivered, or they may leave the person because it's not working and leading to possible neglect. Or there might be a controlled restraint in difficult situations where the person maybe has care completed against their will. So obviously there's great consequences for this. So if no care is given, the person may be dirty or smelly or disheveled. So there's a public threat to their dignity. Or they may have poor hygiene or get urine burns or pressure sores or infections. And if care is given, it could be what we all want is a successful interaction. Or there could be conflict or anxiety for the person with dementia and the caregiver, and stress and maybe coercion. So difficult situations either way. So often if care is given and it's difficult, it can be distressing. And if no care is given, it can be distressing. And at the very extremes of both of these, it could lead to crisis points. So the Procare study was developed to examine this area of care a bit more in detail to find out what we can do to reduce refusals. So one of the objectives was to determine the factors influencing refusals of personal care in advanced dementia in both family and care home settings, examine key components of personal care interactions, including caregivers' management of refusals of care, and then to use this knowledge from both settings to develop something to support caregivers in some way. How can we help caregivers to make better personal care interactions with the person they're supporting? So we're interested very much in the context, the factors influencing refusals of care. So the person with dementia, caregiver, and environmental factors, and also the caregiver interaction between the caregiver and the person with dementia, and how they respond to that, and then what the caregiver may do in situations of refusal. So the Procare study had 5 stages. So the first one was to look at past research. So we did a systematic review, look at what do we know already, what's useful. And the second stage was to ask caregivers about the person with dementia they support, using lots of questionnaires to find out the factors associated with refusals. And then we interviewed caregivers and people with dementia to find out their experiences and perceptions. And then we observed some personal care interactions with video recording these, so that we could really examine what happens within those interactions. And the 5th stage is to develop the findings and produce information for caregivers, and hopefully some kind of intervention to help caregivers. So stage 1, the evidence from previous research. We conducted a systematic review of the past research. So this was looking at interventions, strategies that had been put in place to reduce refusals and whether they worked or not. So we searched lots of research databases to find out all the studies that had happened before. And when we found those, we synthesized all the findings into a narrative synthesis. So we found 36 articles relating to 30 different research studies, and most evidence was from care home settings. And there was no interventional research found in hospital settings, limited research in family settings. So there was one study of slow stroke massage, which had been found really difficult to implement because the family carers found it quite hard to keep up with the regime of doing it. And there was no interventional research in home care either. So what did we find that worked? So there was some evidence that just playing recorded music, like a CD in the background, during meal times and shower or bath times reduced refusals of care. There was some evidence that different bathing techniques reduced refusals of care. So this would be a strip wash instead of a shower or a bath, or a thermal wash using warm, damp flannels and swapping them over to keep the person warm. And also we found that interaction and communication styles were associated with reduced refusals. So reducing elder speak, so that sort of talking in a patronizing way to the person, and perhaps using controlling communication influenced refusals as well. So reducing that reduced refusals. And there was no evidence, there were some studies, but no evidence that aromatherapy reduced refusals of care at all. So we then went on to the second stage, questionnaire study. So our aim was to determine the factors associated with refusals of care in advanced dementia. So we used questionnaires or informant-based measures filled in from caregiver reports. So these started face-to-face with caregivers, but after COVID started, they moved on to telephone and online data collection with caregivers. And we used a descriptive statistics and mixed effects regression models to analyse these data. So what were we looking at? What were those potential factors that we asked questions about? So we were really interested in whether the care settings, either the care home setting or the family setting, had an influence on refusals of care happening, or whether if caregivers had any dementia training had an influence on refusals of care. So some care home staff don't always have dementia training, and some family carers have access to dementia training. So we were interested in both the setting, the professional and non-professional caregivers, but also those who'd had dementia training and those who had not. So we were interested in the person with dementia. So we asked questions, obviously, about refusals of care because it was our main variable. And we created a novel questionnaire through this study, the Refusal of Care Informant scale, and that has been validated through this study as well. And we also asked about neuropsychiatric symptoms using the neuropsychiatric inventory and the Cohen-Mansfield agitation inventory. We looked at functional ability, so the person's ability with activities of daily living, how independent or dependent they were. We looked at their comorbidities. Did they have other health illnesses or diseases? And we looked at their personal characteristics, their age, their gender, ethnicity, and their health status. Were they, at the time of the questionnaires being undertaken, had they had an infection? Were they their usual selves? In terms of caregivers, we assessed the caregiver approach using the Dementia Management Strategy Scale, and also their confidence and training needs in relation to personal care activities. So that was a novel questionnaire developed as part of the study. And in terms of environmental aspects and support, we looked at the home environment, and this was using the Home Environment Assessment Protocol, the HEAP questionnaire, but a reduced version. We were really interested in whether the bedroom or the bathroom had had any modifications to assist with personal care. We looked at whether the person was prescribed and taking psychotropic medications, and also whether the person had had access to support services over the last 3 months. And we used the adapted version of the client service receipt inventory for that. So in total, we had 260 participants. So we recruited in pairs, a person with advanced dementia and their caregiver. So there was 130 pairs. So 106 of those were people with dementia supported at home and their family carer. And 24 of those pairs were care home residents matched with a care home staff member who regularly supported them with personal care. And there's less care home participants due to COVID. We focused more, after it was difficult to get access to care homes, we focused more in the family setting. So most of our people with dementia, we had quite an even gender split. So about half of them were female. And in terms of caregivers, 71% were female. So results from the questionnaires. So we looked at the dementia training for caregivers, and 92% of care home staff had had some dementia training and 27% family carers. And people with dementia had refused care in the last month. So 92% of care home residents had, and 63% of people with dementia supported at home had. And the refusal type most common was verbal refusals, just saying no. And the least common was a physically aggressive refusal. So which factors out of the ones I've just been through were not associated with refusals of care? Well, the care setting, either being in a family setting or a care home setting, was not associated with refusals of care, which we thought it might be. And whether caregivers had had any dementia training or not was not associated either. In terms of the person with dementia factors, neuropsychiatric symptoms as assessed by the neuropsychiatric inventory were not associated, nor were comorbidities and other health conditions. And personal characteristics of the person with dementia were also not associated. Caregiver approach and caregiver confidence and caregiver training needs were not associated either. And nor were the home environment adaptations, psychotropic medication use, or input from support services in the last 3 months. So what was associated? Okay, so the 2 factors were associated with refusals of care. And one of those was the neuropsychiatric symptoms as assessed by the Cohen-Mansfield agitation inventory. So this questionnaire assesses practical demonstrations of agitation. So where the person with dementia is expressing some feelings or by doing things like having general restlessness, hiding things. So quite practical expressions of how they're feeling. So agitation, higher agitation was associated with more refusals. And functional ability, so independence with activities of daily living, where we found that the more dependent the person was, the more likely there were to be refusals of care. What we don't know is the reason for the agitation. We don't know what's behind the agitation. That's a limitation of this section of the research. So we also found lots of other things. I'll just going through a couple here because there's too much to go through today. But we found that caregivers had been physically hurt when providing personal care assistance to people with dementia. So 75% of care home staff in the blue here had been physically hurt, and 19% of family carers had been physically hurt in the past. And in terms of feeling difficult emotions when providing personal care assistance to people with dementia, Over half care home staff had felt difficult emotions, and these were like frustration or anger. And 75% of family carers had felt difficult emotions when providing care. Okay, so stage 3, we moved on to interviews. And we used semi-structured interviews, and we audio recorded these and typed them up into transcripts afterwards, exactly as the words had been said. And we analysed these inductively, which meant we looked at the data to see what was there rather than putting our own thoughts onto the data. We looked at bottom-up approach, thinking what is our data telling us here? And we used inductive content analysis there, qualitative. And the aim of this stage was to examine the caregiver's experiences of managing refusals and to explore the experiences of people with dementia when receiving assistance with care. So we interviewed 20 family carers, 12 care home staff, and 13 people with dementia. Now, some of the interviews with people with dementia were also with the caregiver for support, and some of them were very short as well. We just did what the person felt able to do. So in terms of the percentage of female, the family carers, 85% were female, care home staff, 92% were female, and the person with dementia, 54% were female. And our family carers had been caring for more years than the care home staff, so average 5 years, and care home staff average 2 years. Okay, so the findings from caregivers. So we came up with several themes. So this one is finding the right moment to care. So this involved the caregivers leaving and returning later. So if the person wasn't receptive to receiving any assistance at that time, they would leave and try again later. It was a top strategy that caregivers would resort to. And sometimes they would change the time of care. So if the person, it was no good trying to wash the person or shower in the morning, and they were much more happy to have a shower later in the day, the time of care would be changed. So caregivers were flexible. And especially in the care home settings, there was a key theme of addressing unmet needs first. So does the person need to go to the toilet before we start doing the rest of their personal care? Do they need a cup of tea? You know, getting those unmet needs addressed first. Also, caregivers use specific communication strategies. So there was lots of encouraging and explaining. And especially in the family settings, they talked about showing emotions. So perhaps they would become frustrated or upset and show the person that as a way to try to get the person to receive the assistance of care. Being firm was in both settings, but it was quite differently presented. So perhaps in a family setting, the family member might say something like, "Don't you dare," if the person was becoming cross and angry. Whereas in a care home setting, it was very much like, "Oh, come on, you don't hurt women," things like that. So it was the same being firm, but in a very different way of saying it. And also lots of the caregivers described care positively. So, "Oh, come on, we'll have a lovely bath," or "We'll just quickly do this. Let's pop your top on." So lots of little words to make the care activity sound much more positive. There was lots of simplifying or adapting care. So providing reduced care was one way that caregivers managed. If the person with dementia wasn't receptive to care that day, they would give them just a smaller wash rather than going through the full routine. Sometimes care was left uncompleted. So maybe the person would have a dressing gown day if it wasn't urgent care. And sometimes changing the mode of care was employed. So a strip wash rather than a bath, using dry shampoo rather than a hair wash, perhaps letting the person's whiskers grow rather than a shave every day. And caregivers try to maximise their confidence in care. So they used routine for this. They stuck to the person's routine and very much felt that the routine was a support to help the caregivers get through the care and reduce refusals, because it was what the person was used to, and they both knew what was going to happen. And distraction was used. So sometimes this was verbal distraction, talking about the person's hobbies or family, or sometimes it was a physical distraction, asking the person to hold something while other care was taking place. Caregivers in care homes were very much keen on employing a cheerful approach when they went in, and said that very much if you go in with a smile on your face, you're much more likely to have an acceptable interaction. And sometimes continuing with care occurred. So this was used in our data very infrequently mentioned, but in family settings, perhaps it would be a feared task such as nail cutting that had been repeatedly put off, and the caregiver would resort to just getting it done as quickly and as carefully as they could, just because it was never something that the person would agree to. And also creating time for care, so making sure there was that time to go through the procedures of care and not being rushed. Seeking support from others was really different in both of the settings. So in care home settings, it was very much around calling on the staff team around them. There was somebody there in the moment. They could go in pairs using more than one person. They could say, oh, I'm not getting on very well this morning here, can we swap? And so there was lots of flexibility and support within the staff team. Have you got any techniques or strategies I can use? So they had people to ask. Whereas in the family settings, family carers were struggling a bit more on their own. So sometimes they had a family member or a neighbour they could call on, but generally it was using formal health or social care support. So services, so maybe the GP, a nurse, or maybe home care services. So just a little example of the data here. So finding the right moment to care, so changing the time of care. This family carer says, if she falls asleep in the evening, she doesn't know where she is. So getting her clothes off or her pajamas is difficult. And I've realised I've got to get there and do things before. So it was about changing the time of care to fit the person. And then using specific communication skills. This is a family carer showing emotion. I feel tearful sometimes. I say, why do you have to go through this every time? What do you think it does to me? I'm showing my frustration. And that was one way she tried to get the person to move forward with the care activity. Here, a care home staff member is talking about simplifying or adapting care, so changing the mode of care. She doesn't like showers, and she definitely doesn't want, so I wouldn't push her to the point to say you've got to have a shower. I can give her a good wash and probably check her better as well. So having a strict wash rather than a shower. And here a family carer is talking about maximising confidence in care, creating time for care. So on the day centre day, it was a bit hard for me. Chivvying the person along to get ready takes time. So what I need to do is get up earlier on a Thursday morning because we need to be there at 9 a.m. So the caregiver again was adapting to make sure there was time to go through the care interaction and make it acceptable for the person. And seeking support from others, using more than one person, which was a key strategy in care homes. So a care home staff member saying, if there is two of you, one can actually talk to him face to face and the other one is assisting. So very much if they went in twos, they didn't both try to do the activity. There was one doing sort of the communication and one getting on. In terms of findings from people with dementia, we found that people with dementia liked being kept warm during care. So I hate being cold in the water, says a person supported at home. And they also like their relationship with caregivers. I like things like that. It's done when you're chatting to each other. So having the personal care done while you're having time in a relationship with the caregiver was really liked by people with dementia. People with dementia disliked being dependent in the first place. So I would really like to be doing things for myself, a person supported at home is saying here. And also people with dementia talked about adapting. So they had to adapt to new routines and practices. I've been told to go to the toilet like women do, sit on it. There's a male person supported at home. So he's having to adapt his practice to make it easier to manage. And also they had to adapt to having assistance with care. So here a care home resident is saying, it's really strange. You get your hair very, very wet and their hands are fiddling about on you. you know that it's being done properly. So it was about adapting to having somebody else doing the actual action, but actually there was this reassurance that it's a good wash. I'm getting a good hair wash here. So stage 4 are video recorded observations. So the aim here was to explore refusals and engagement, and also key components in personal care interactions. So both successful interactions and more difficult interactions. So between care home staff or family carers and the person with dementia they supported. So we video recorded observations of real-time interactions, and caregivers and the person with dementia, if they were able, chose the activities that they wouldn't mind being observed. So these were often teeth cleaning, nail cutting, assisting a person to eat, a hair wash, using a foot spa, or morning care, but not when the person was fully uncovered. So once the person had their underclothes on. Analysis was inductive qualitative content analysis. And our participants were 14 pairs that we video recorded. So we had 5 family carer and person supported at home pairs. And we had 7 care home staff take place, but 9 care home staff pairs and 9 care home residents. So 1 care home staff member paired up with 3 different residents in 1 care home. So our caregivers were 100% female. Unfortunately, it would have been nice to record some male caregivers. 57% of people with dementia were female. So we, in the end, had over 3 hours of video recorded observations of 26 different personal care activities, such as morning care or teeth cleaning. So let's look at the positive interactions. So in these, the person with dementia was sort of focused and engaging. So this kind of focused engagement was seen. So the person was sometimes seeking reassurance. They were checking with the caregiver. Were they doing the right thing, or is this what they had to do? And also they were showing a bit of apprehension. So they felt very comfortable in the interaction. They could show that they were wary or worried. But they were also participating in the care very heavily. So even if they were unable to actively do the care, if it meant that they were lifting their chin for a shave or opening their mouth for teeth cleaning, they were actively participating. They often gave their assent or consent. And when they weren't actively participating, they were intently watching the caregiver and what the caregiver was doing. And also we saw instances of pleasure, particularly one lady who was washing her hands in some warm water and wiggling her fingers in it and really enjoying the experience. In terms of caregivers, in the positive interactions, they were showing a nurturing kind of attentiveness to the person with dementia. So they invited the person in to be part of the interaction. There was a real togetherness. Shall we wash your face now? We'll just do this. So it was very much a we. And there's also permission seeking, asking the person, even if it was in the form of a question, shall we just clean your teeth? You know, inviting the person in. There was also a lot of putting the person at their ease. So care home staff particularly demonstrated familiarity with the person. So they would talk about the person's family or what they did with the person the other day, and talk about familiar aspects between, to show that there is a relationship there and remind the person that they knew them. In family settings, there was much more use of praise while doing care. And also in both settings, lots of reassuring, and this could be verbally, but also non-verbally as well. The caregivers guided the person through the care activity, so there was clear instructions. There was, again, as we heard in the interviews, we saw in the videos that they were talking up the care activity. Oh, we'll have a lovely wash, we'll just do this, we'll quickly do this. Oh, it'll feel really nice. There's lots of talking it up. Non-verbal communication, again, eye contact was used, touch of the shoulder. And then there was this kind of use of instructing and endorsing. So often the person would say, okay, wipe your mouth, that's right. Or clean your teeth, very good. So it sort of told the person what to do, but then also reassured them and endorsed them that they were on the right line. So really quite a nurturing communication method there, and lots of encouraging took place. And caregivers really show an attunement to space and pace as well. So they weren't hurrying the person, they positioned themselves inoffensively away from the person, but not too far away, just not so they weren't in their space. And then the pace sort of kept the person moving through the activity, so didn't allow them to lose their concentration, but it wasn't hurrying. So in the difficult interactions, there was lots of what we've just talked about, those kind of nurturing actions, and lots of participation from the person with dementia. But there was also this kind of feeling uneasy. So the person with dementia was tolerating uncomfortable care at times. Sometimes they would moan, or sometimes they would wince or close their eyes. So there was some of that we could really see by analysing video recordings, because it enabled us to go back and look very slowly at what was happening. And also people with dementia sometimes struggle to get their perspective across, and they might be trying maybe to refuse or show their uncomfortableness with the care activity. And sometimes it was hard for them to get this across to the caregivers. And caregivers seem to fluster a little bit in these interactions, although they were doing lots of the lovely nurturing attentiveness stuff from the previous slide. They were also having difficulties interpreting that communication. So sometimes the person with dementia was giving mixed messages, sorry. So they may open their mouth, but also start moaning. And the caregiver then had to decide, are they agreeing to have the care done or not? So it made the caregiver fluster a little bit, trying to interpret the communication. And then they started to perhaps provide pressured care, so hurrying the person along because they became flustered and persisting when the person perhaps would rather be refusing. So these interactions give us an idea of what doesn't go well when it's a difficult interaction for both the person and the caregiver. So stage 5, we're now at the stage where we are developing our findings. So we've talked about the observations, the interviews, the questionnaires and the literature, and they're all the findings are feeding into those. But also we've conducted some workshops with dementia specialists and clinicians and caregivers, so family caregivers and care home staff members who do conduct personal care with people with dementia or have done. So our first workshop was to determine what have we got in our findings that's useful and what we want to take forward and what perhaps we want to leave behind. And the second was how best what can we do with these findings, and what are the possibilities here to take these forward. So as part of developing our findings, we've created a booklet called Assisting People with Dementia with Their Personal Care, Ideas and Tips for Carers. And these have been collated throughout the study from our participants and discussed with our advisory group and developed into a booklet. So this is a draft booklet at the moment, and it's going to be refined from feedback from the workshops. But this is just a snapshot of it, what it looks like. And there's pages for each care activity, so dressing, going to the toilet, eating and drinking, things like that. So what did we find in the workshops? Well, we really found the value of our findings. They really resonated with the caregivers on the ground, care home staff and family carers. So it really showed that we have something good to take forward. And the professionals, dementia specialists also thought that as well, and thought there were some really good ideas to bring forward to help caregivers in the future. So those dementia specialists were occupational therapists, care home organisation dementia specialists, clinical psychologists and gerontologists. So we also found useful things like I mentioned to take forward and those to leave behind, ideas to revise and improve our booklet, which will, before we disseminate it, which will make it a lot better. And also priorities for developing the findings into training or other support for caregivers. So these we found through the workshops and looking at our findings that actually they would be different for each setting. Care home staff very much preferred group sessions from our findings, and family carers very much preferred more individual discussions. And also we developed some collaborative partnerships for the future. So far we have the booklet, we have finding summaries, infographics and pamphlets. And in the future, I'm hoping to develop a new grant application to conduct another study to develop these findings into a training intervention and evaluate that. So hopefully some educational resources. Obviously, we're going to revise the booklet and disseminate that as well. And then what can we conclude from the fellowship? So obviously music played in the background and different bathing techniques and communication styles have the potential to reduce refusals. Agitation and dependence in activities of daily living are associated with refusals. Caregivers use multiple strategies to prevent and reduce refusals occurring. And people with dementia like to be kept warm, and they like the caregiver relationship during personal care. They don't like being dependent, and they are quite aware that they're adapting. And most personal care interactions were successful, the ones we video recorded, and caregivers were really skilled in assisting people with dementia. And people with dementia really participated in care to the stage where their abilities allowed them to. And difficult care interactions were so both for the person with dementia and the caregiver. So there's lots in the literature about the behaviours or the actions of people with dementia being challenging for caregivers. But our data also show that the actions or behaviours from caregivers can be challenging for people with dementia in those interactions as well. And we are developing our findings going on from here now, hopefully to support caregivers. So I'd just like to thank the Alzheimer's Society for funding the study and my supervisors and colleagues, Aneda, Anne, Lizanne and Yan Hee, and also the study advisory group who are family carers of people with dementia and care home staff looking after people with dementia there. So Julie, Peter, Derek, Claire and Emily. And there's the references. Thanks very much for listening.
Fantastic. Thank you very much, Tamara. If you, that's it, perfect. Excellent. I think it was a fantastic overview of your study. Yeah, have a well-deserved drink and a well-deserved round of applause from everyone. So if you have any questions, please come on and ask your question or type them into the chat if you want to. Maybe I can get us started with a question to see, kick us off while you're all still thinking about questions. So I was really interested in the agitation finding in the questionnaires, but the questionnaires, of course, they ask about agitation usually over a long-term type period. So I was wondering, did you see also the agitation actually in the session when that happens? So well, put it differently, are people agitated first and that causes the refusal of care, or do they become agitated during the care and therefore refuse it, I think?
Yeah, that's a really key question, Michael. So the questionnaire, the Cohen-Mansfield Agitation Inventory, asks about agitation actions within the last 2 weeks. So that's where that data comes from. And obviously in the moment, when we did see difficult care interactions, and they were limited, the difficult ones, when we did see those, the person seemed to be maybe already in some kind of state of expressing emotions, but then the interaction inflamed that as such. So the caregiver's approach and sort of persistence and hurrying really heightened that feeling of agitation for the person. So yeah, I think there are two things. There's a general state, but also within personal care interactions, refusals usually occur because of the interaction and because of what's happening to them. And it may be they don't understand the caregiver's intentions. So, you know, I think understandably, if we didn't understand and somebody tried to undress us, we may refuse care. So it's quite understandable sometimes as well. Most of the
absolutely.
time.
I agree. I think that makes a big difference, doesn't it, for the strategies one can use. If somebody's already agitated, it would suggest more to maybe leave it and try later, or try something out. And while if somebody gets agitated, maybe it's about changing tack and what you do actually. I don't know. Yeah, that's. Anyway,
that sounds like and lots of the interview findings were very much around making sure the person's receptive before starting any care. So there's something there as well. If the person seems to be agitated, perhaps there's some work to do first, either in the calming work or leaving the activity for a short time.
Great. So then we have the chat, and there's a lot of comments already that people thank you and found very interesting. And we have several questions on when and where people can get the booklet. So no pressure, Tamara. Where is it?
So at the moment, the workshops are just completed. So I have some work to do refining it, and there's some really good ideas from our workshop attendees. So it's there in essence. It just needs some tweaking, which shouldn't take me too long, and then it will be hopefully put on the UEA website. Perhaps we can distribute it with the Dementia Forum email circulation.
We have to think if we can do it ethically, but I think the easiest, if people are interested, maybe can they email you, Tamara?
They can email me, but it will be put on the UEA website and disseminated more widely as well. So yeah, it will be available. Definitely, you can email me. I'll put my email in the chat.
Maybe we can put your email address again in the chat later, so people who are interested, or you can put it now, and then we can put it several times. So then we have a question from Sean Day. Thank you, very interesting. I work in a team. Sorry, are you still typing?
No, it's fine. I'm listening. Yeah.
I work in a team that supports care homes and support these situations on a fairly regular basis. We see distress behaviors associated with these situations. What do you feel of the need to know about a person's life story or pre-morbid personality and experiences which can influence a person's response?
Okay, yeah. Now this, interestingly, didn't really come up in our data, didn't come up in the interviews with caregivers, a small amount with the care home staff, but very much in our workshops, the care home staff and family carers felt the basic fundamental here is knowing the person and knowing the life story. So yeah, I think there's a key role for it. It did come in the interviews, a small amount with care home staff saying first they need to know about the person and their background and what they like and what they don't like. So particularly with care home staff, where the person may come into the care home already cognitively impaired and perhaps with communication difficulties, it's harder to find out about that person. So yeah, there was a bit of peddling there for the care home staff to get up to speed with the knowledge of the person so that they could then tailor and adapt their care to that person. But obviously in the family settings, that was already there. But what wasn't there in the family settings was a basic knowledge of underlying care strategies and how to conduct care. So in terms of care home staff, they had to get themselves up to speed on the person, and in terms of family carers, they had to get themselves up to speed on providing personal care and what that entailed and how to go about that. So yeah, I think it's a really key point and really can facilitate better care interactions if the caregivers know the person.
Yeah, I think that makes really sense. Yeah. So then Russell Simpson has a question. So you said training providing care didn't necessarily make caring any easier, although it seemed it might have been better in a care setting. Can you recommend any training streams for carers? I guess Russell means here maybe more for carers at home, I guess. But, yeah.
Okay, so I think training is really difficult to recommend at this point, because we saw that those who had dementia training, it didn't make a difference. It wasn't associated with refusals of care. So I'm wondering whether the type of training people had accessed included the relevant strategies and whether it was relevant to personal care, because some dementia training can be, this is what dementia is, and not tailored personal care. So maybe that's why the training in our study didn't have any association with refusals or reducing refusals. In terms of recommending any training, that's a difficult one. I'm hoping to develop some. So maybe in a few years I could really recommend some that have come from these findings that we hope to develop on using some psychological theories to really underpin those.
But are there any existing, just really basic care kind of trainings? Maybe not. Are you aware of that? Maybe. Sorry, I don't want to put you on the spot.
It's really difficult because some are only accessible to certain, lots of care homes, for instance, have in-house training, and some family carers can access training but it depends on where you live and what's available where you are. So it's a bit of a postcode lottery in that sense. But one, you know, there may be a future learn training that comes up online. There's sometimes local councils are linked to training in terms of there's certainly a booklet that the caregivers I've spoken to have found really useful that can signpost caregivers to help and support. So and there's leaflets on the Alzheimer's Society website about different aspects of caring for a person with dementia. So.
Great. And Jenny asks, I haven't heard of elder speak. Could you give some examples of what this is, please?
Yeah, okay. Yeah, it's a term used in the academic literature, but it really means talking to the person in a patronizing way. So using sort of really exaggerated, slow speech, or making the person, you know, maybe how you would talk to a very young child, you know, that kind of high-pitched tone of voice, and you know, just in a patronizing way where the person may feel not respected as an adult.
Then Liz Woody is asking, really interesting, how did you define dementia training, Tamara?
Yeah, so we just let the we let the participants self-define. So have you received any dementia training, yes or no, basically. But then if it was yes, we did ask about the types of dementia training and what it entailed. So we do have those data. For the statistical analysis, it was yes or no, have received dementia training, because the dementia training was so sometimes it would be an hour's online video, sometimes it was quite, it might be a face-to-face session, or it might be about what dementia is, or it might be about a simulation of dementia, so wearing the goggles. So there wasn't a unified dementia training with our participants.
Great, and then Tabitha Griffin wrote me a direct message. What are Tamara's thoughts about how her research links to adult safeguarding and the MCA? The mental capacity, sorry.
Yeah, Mental Capacity Act. Yeah, okay, so yeah, it's really difficult. So in terms of research, obviously, we got consent using authorised Mental Capacity Act. We did a capacity assessment, and if the person wasn't able to consent, we used a consultee, so a family member or close friend who knew the person well, to advise us on whether they would have liked to take part. But in terms of caring when somebody's refusing, quite difficult, because there is that instance if somebody refuses care and the care doesn't take place, that, you know, leave and return later, that's fine, but how long can you leave somebody who may be at risk of urine burns? And there is this kind of line that's really difficult, and we haven't resolved that with this research, unfortunately. If care doesn't take place, or if it does take place, like the person who continued cutting the nails just because it had been put off so many times, those kind of things could sort of lead to neglect and abuse, and it's a really thorny area, and really links to safeguarding. It's really hard, but people taking part in our research were probably those unlikely to be providing care that they felt was, you know, not safeguarding the person.
Yeah, and there's a comment by Jacqueline Green who says that Suffolk family carers run educational programs. So that's something for people maybe to check out, to Google. And Ellen said that she finds Teepa Snow very helpful. She has a number of YouTube videos.
Yeah, Teepa Snow is great for advising how to approach the person in a really person-centered, a really inoffensive way. So they're really worth looking at, those videos. They're on YouTube.
Yes, yeah. And then Gail Hamsley says, I work in Sean Day's team, and some of our staff currently do workshops in the care homes. He said, you're looking to do some future training around personal care. It would be good for us to be able to keep up to speed with your future work. Is there a way we can do this?
Yes, please do get in touch. My email address is on the chat. Please, email, or in terms of, so that I can keep you updated. But yes, I'm sure when it's happening, I will be doing perhaps another Dementia Forum talk.
Yes, yeah, well, then we'd love that. Then Wendy Chart is just saying that Home Instead is also providing training areas for family carers in some areas. So again, something to look up. And then Liz Wood is just saying, thanks, Tamara. There's certainly a gap in tailored training for carers, paid or unpaid, for people with dementia. I guess we can all agree on that one. That's, yes. Just to finish us off, I show you, this is our next speaker. So on the 21st of April, we will have Aida Suarez-Gonzalez from UCL, and she will talk about practical tips to support activities of daily living on people with dementia-related visual impairment and apraxia. That's her specialty, really, especially PCA. And so she has developed tools actually which can help with that. So I hope this will be of interest to many people. I also tried to convince Aida because she has emerged actually as one of the leading people who investigates COVID and the impact of COVID on dementia. So I tried to convince her to maybe speak very briefly about that as well, which I think is of lots of interest to many people. But yeah, if you can join us, that would be fantastic. Again, you can find the details on our website. Yes, with that, I just want to say, yes, Dan just put this again in the chat where you can find our website actually. And with that, just wanted to say thank you again, Tamara, and an applause for you. Thank you so much, it was fantastic. And thank you all for coming, and see you hopefully next time.